Welcome. In this video, we will talk about real-time modeling, or RTM. Joining me today is the RTM team, who are at the heart of the Imperial College COVID-19 response team. They've been working on the COVID-19 epidemic in the UK throughout this year and will talk us through what it is that they do. Mark, you have led the real-time modeling team for the last 9 months. Can you explain what real-time modeling is?
So at the heart of it, we have a mechanistic model, so a set of mathematical equations. And what we're trying to do is to try to reproduce the transmission of the SARS-CoV-2 virus. And the idea is to produce all these estimates that are informing policymakers or allow people to track the disease. So basically, there's a lot of things that you don't observe. And what we're trying to do is to reproduce the transmission that we don't see, but that we observe indirectly. So it's really something that takes the data from the surveillance and transform it using algorithm and math into quantities that are epidemiologically sensible and that can inform policy and can explain what's happening. And we do that for each NHS region in the UK. So we have tried to get kind of a local picture of what's happening.
So you say that starts with a whole lot of data. So the key to that is data. Katie, can you tell us more about that?
So timely data is vital for any sort of real-time modelling. And we collate information from a number of different sources. So we manage about 15 incoming data streams every day. These change over time as data collection improves or the questions of interest vary. And as such, it's kind of a constant task to keep on top of the changing data. However, this doesn't just summarise the change in the numbers. We need to understand the narrative of where the data is coming from and how it's collected, which hopefully helps us interpret it and use it appropriately in the modelling. So some of the data we use describes new cases in the community or hospitals, but we also use information on deaths, like where and when they occurred, as well as information on people's exposure history, which is measured through seroprevalence studies, or even just on the number of tests that are being conducted and whether they're positive or negative.
So that leads me to Rich. You lead the research software engineering team in the centre. What is research software engineering?
Research software engineering is an emerging field that's sort of turned up in the UK over the last 10 years, and it combines aspects of professional software engineering with research. Basically any research that's done on a computer now could be considered research software engineering. Within the centre, we have a group of professional software engineers that sits more at the software engineering end of that spectrum, where we try and build tools that underpin the research that the researchers here do.
And how has rigorous software engineering helped this particular project in the real-time modelling?
In a couple of ways, I think. One of them is in the data pipeline that Katie mentioned. We have well-tested tools that sit behind that and try to make that job of keeping on top of the ever-changing data straightforward. It also sits behind the models that Mark described, providing some well-tested foundations that the epidemiology can be expressed in, so that the scientists don't have to worry about implementing all of the physical model themselves.
Great, thank you. Wes, you work on data collation and validation pipelines. Can you explain what this is and talk me through how these feed into real-time modelling?
Yeah, so we download a range of different files each day. Some are from public sites and others private, and some by email, and they come in a variety of formats which we collate together into a standardised format which all of the different groups can use. We'll then check that the different columns in each data source haven't changed, and data formats match what we expect, so that we're aware of any changes in that data and adapt to it so that we produce the same format each time. Then the data is human validated as a final step before projections are run using that collated data to pick up anything that the computational checks might have missed.
That's really interesting. And you also mentioned the orderly framework. Rich, can you explain what that is?
It's a set of conventions really for capturing analyses at the point that they were run, and making it easy to get back and investigate later on. Tries to take away some of the drudgery of rerunning things over and over again by hand, and avoid some of the homebrew solutions that people typically come up with for that.
Thank you. John, you're one of the key software developers on the project. What are some of the challenges that you faced?
One of the most difficult things about this project is that to represent the variation in the process and explore all the different possibilities, we need to reproduce some of the randomness within computers. So that in practice means generating lots and lots of random numbers, which are fair as a coin toss or a roll of a dice, which of course you can't get a computer to do. So getting it so that we can generate all those random numbers very quickly, and also because we need to, it takes a long time to generate this many random numbers, we need to split it up over multiple machines, getting it so that all of those random numbers are fair across the machines, and when we put it back together, it gives the same results, and it doesn't matter how many machines you run it on, was quite challenging. And when it all worked out, it was good to see how much it sped the code up. And how it fit into our schedule of being asked to complete tasks. And the final result is something that's reproducible, so people can get the same results that we did on whatever machine they have. And all of the code to do that is available on the internet for anyone to download and look at.
Just to give me an idea, how long does it take to run a model?
I believe at the start, before we introduced this code, we were kind of getting up to 12 hours for the model to run. It's getting longer all the time because we've got extra days of information that we fit to. But I believe after these changes, it was down to 1 to 2 hours.
Actually, it's not about the model. It's actually we're running a lot of iteration of the model. So we're trying to explore all the possibilities of the transmission, and we weight all of that with probabilities based on the data. So how well we're able to kind of reproduce the data, and it's what takes a lot of time. So it's why we do this exploration kind of in parallel among multiple cores of the computer. That's why it takes so long, because it's all based on kind of random number generations. If you have a very fast way of generating random numbers in parallel, you manage to speed things up.
Amazing. Bob, you led the analysis of hospital data specifically. Why is that important, and how does that feed into the broader RTM work?
So as Katie and Wes mentioned, there's multiple data streams that are going into this model fitting. And actually, I think that's the real strength of using a model in the first place, is that it allows you to bring together these different data sources, which can give you much more power than just analysing them individually. In my case, I was focusing on some data called CHESS, which is the COVID Hospitalisation in England Surveillance System. So CHESS data is a line list, which is the kind of gold standard in epidemiology terms. It means that for each patient, you just have kind of a row of a spreadsheet, and you have their age, the progression through hospital, their clinical treatment. And in fact, there's a huge number of columns in this data set that I didn't even touch, and people will be kind of mining this data set for many years, I'm sure. The thing that I was interested in is what happens to people once they enter the hospital system. So do people go to ITU? Do they stay in general ward? What's the probability of becoming critically ill and having to go to ICU? And then the chance of either recovering and being discharged or dying, and how that varies with age. So there's very strong trends with age with a lot of these things. We know that everything to do with COVID severity is very age stratified. So I did a kind of in-depth analysis of this CHESS data, and I then fed these results up to the wider model. So the thing that CHESS can't tell you is what's happening outside of hospital. It's kind of a very focused, very granular data set, but it only tells you about that one aspect. So my analysis was then teed up to the rest of the group, who then combined it with the other data sets to get an overall picture for the UK.
Okay. So overall, there are different questions that you're trying to answer with this model. There's weekly standardized analysis that you and the team run at. Can you tell me about the procedure for IM and eventually SAGE?
So we run the model on Monday against the very latest data that we've got, and we output a range of estimates to account for the uncertainty. So we output these estimates for some things like the kind of current reproduction number, the current growth rate, the current level of infection incidence in the population. We do that for the NHS regions of the UK. And then we also do some additional forecasts. So just basically saying, if kind of the trajectory of the epidemic continues along at the same level as it is currently, then what would we expect to see in terms of hospital bed occupancy, maybe ICU occupancy, infections and deaths over the forthcoming weeks?
And in addition to these standardized weekly analysis, the real-time modeling team also does a lot of scenario analysis. Lilith, can you explain what sort of things you have looked at?
Yeah, sure. So as Ed's just very well explained, the weekly reports that we send to SPI-M measure where the epidemic is now and what might happen in the short term if transmission remains at the current levels that we're seeing. But we can also use our model to examine what might happen if those patterns of transmission change. So, for example, we often perform analyses of the potential impact of different policies that are being discussed in government, such as you may have heard of, circuit breakers or local lockdowns, and also the rollout of vaccination.
And so we're all very excited to see vaccines being rolled out at the moment. What has the team been doing to look at the likely impacts of vaccinations?
We've been doing a lot of work to look at vaccination and its likely impact, particularly of the different vaccines that might be adopted in the UK, how levels of vaccine uptake and potential vaccine hesitancy might affect the overall impact. And also the real key question is how soon vaccination might enable us to safely relax all these non-pharmaceutical interventions that have been in place across the whole country throughout 2020.
Thank you. Pablo, you are not only an epidemiologist but also a medical doctor. As a member of this team, what value do you think real-time modeling can bring to health service provision and planning?
Well, I think that my colleagues have given a very good picture of all the different aspects that are involved in modeling. As a clinician myself, I've had the privilege of practicing across many different settings, hospitals, public hospitals, private hospitals, slum clinics, you name it. Regardless of the sector where I practice, one of the things that is very clear to me is that everybody involved in this chain of decision making, whether you're a politician, a clinician, or a planner, you need to be aware of the clinical context and the epidemiological context surrounding your decisions. So one of the things that we are able to provide this chain of decision makers in the UK is timely data, robust data that allows them to be informed of the epidemiological context of the COVID epidemic in the UK. I strongly believe that having this information at hand has an impact in the decisions, and more so decisions that we make today, whether it's as politicians, planners, implementers, or frontline clinicians, do have rippling effects in the days, weeks, and months to come. So definitely for providing life-saving care throughout the NHS, having this information at hand is of the utmost importance.
So real-time modeling seems to be very versatile and adaptable. Neil, how does this work contribute to the wider COVID response?
Yes, I mean, throughout this pandemic, the work of multiple research groups across the UK has been informing government policy making heavy use of both analysis and modelling. And as you've heard, as the pandemic has progressed, we have got more and more data that's become available, and we have a very detailed picture of transmission in the UK. One of the key things models such as this does is to pull that data together, synthesize it, and produce estimates which are directly relevant to policy making. To give an example, one of the critical things we haven't always been able to predict ahead of time, but we need to track and evaluate, is what is the impact of interventions. Going all the way back to the first lockdown, predicting when might deaths peak in April, and then how quickly the epidemic was declining in different areas. Going forward now to what has been the impact of the different tiers in place across the UK in controlling transmission. In those cases, you basically have to rely on a model, because any one data stream doesn't tell you the full picture. But by pulling the data streams together, you can get a kind of synthesis, and that then goes back, as my colleagues have shown, and feeds into policy through initially the SPI-M group, which pulls together the work of multiple modelling groups, and then eventually into SAGE and the Cabinet Office.
And both for Mark and Neil, from your perspectives, what are the priorities going forward in this pandemic for real-time modelling?
The situation is very different from the one in March, so we understand better the transmission. We have a vaccine now. We know that some interventions do provide an effect and can be used, but that they are very costly. The priority is really to be able to transition to a situation where COVID is just a kind of benign disease in terms of not too much transmission, and we manage to protect the most vulnerable. So something like flu, which is very bad, but it's not creating the same level of crisis. So I think modeling will be very important in monitoring the change in behaviors and the relaxation and potential reimposition of social distancing kind of measures, and to really optimize vaccination to protect optimally the population now that we have it. So it's really managing to the way forward with vaccination and non-pharmaceutical interventions.
So one of the things in this pandemic is there's been very few periods where every week or at least every month something unexpected hasn't happened in terms of both the trends in the epidemic, changes in policy. Now it's even more unpredictable. I mean, we don't know ahead of time how quickly we'll be able to ramp up vaccination coverage, what people's behaviour will be once they get vaccines. So one of the critical things is to use real-time modelling to track the epidemic at quite a local level, to understand what's the impact of things like rolling out vaccine. And that will inform us and inform policymakers how quickly those interventions can be relaxed. And then we have additional things. People will have heard of this new variant of the virus, which has emerged in southeast England. That may have different properties, both in terms of how easily it can be transmitted, maybe in terms of how a vaccine affects it. And so you always have new things coming up which you have to factor in. And the real-time modelling gives us an insight by pulling all this data together in terms of how these changes are going to affect policy making and people's lives in future.
Great. Thank you all so much for your time and being here, explaining the amazing work that it is that you guys are doing.